The following animation is made possible through the use of Doodly software and exists for strictly academic purposes. Before the presentation, it is important to state that viewers of this animation may be triggered by the subject material. We will be discussing HIV, female circumcision, domestic abuse, and the latent effects created by COVID-19. Viewer discretion is advised. The prevalence of HIV in southern African countries, including South Africa, Swaziland, Botswana, and Western Kenya, have been places of great interest for researchers as to why HIV is at such high rates. In these areas, an estimated 40 million people are living with AIDS. In May 2006, the Southern African Development Community and UNAIDS hosted a meeting that had reached the conclusion that the reason for the high rates of HIV in these countries was because of a large sexual networks and lack of male circumcision. This led to a research study to test if these were the true variables of high rates. And if it was successful, the nation would then be made aware of the dangers of having large sexual networks, as well as to promote an increase in male circumcision. From a study in Mawali, 1,000 individual sexual networks were deeply studied, and it was found that of these people, 65% of their sexual networks were connected in some way or another. With large networks like this, it is incredibly easy to contract and spread the disease, as the first 3 weeks of contracting the virus are the most contagious. This is known as viral load. This can be a problem as some women use sex as a way for economic exchange. By doing so, women may not have the control to choose when, where, and if condom use will be required. And some research and understanding in June 2006, the WHO had addressed HIV to be a major public health concern. Condom use is heavily promoted, as well as the pressures to decrease the amount of sexual partners one has. Largely, the issue was defined as sexual concurrency. And sexual concurrency is defined as overlapping sexual partners or sexual intercourse with one partner occurs between two acts of intercourse with another partner. It is extremely important to understand that these past assumptions about concurrent sexual partnership explain HIV/AIDS on a personal level, based on individual choice. While there is evidence that partner reduction campaigns in both Kenya and Uganda saw a reduction in the spread of HIV infections, the reality is that sexual intimacy is by far not the only contributing factor to the spread of HIV infection in southern Africa. This behavioral presumption dominated the academic literature in the 1980s. However, its myopic view of individual choice over environmental causes does not hold up. And to understand HIV infections as being correlated to sexual behavior is a limited socio-political analysis. For example, there are numerous common medical blood exposures that include injections with unsterilized syringes, blood transfusions, catheter and intravenous placements, as well as barbering and hairdressing, tattooing, scarifications, injection given by non-medical personnel, and intravenous recreational drug use that all have the potential to contribute to the rate of spread of the HIV infection. Furthermore, the assumption that Africans are more sexually promiscuous is an assumption that has epistemological roots in racist stereotypes. As students of sociology, it is crucial to understand that scientific research is often corrupted by pre-existing prejudices, cultural assumptions, and ethnocentrism. The idea that Africans are hypersexualized is not a reality. For example, evidence from surveys on sexual behavior suggests that African sexual behavior was more conservative than in Europe, the United States, Canada, and Latin America, casting doubt at the behavioral paradigm. Furthermore, when accurately measured, concurrency in sub-Saharan Africa does not occur at an increased rate. Therefore, the last bulwark of the behavioral paradigm is without empirical or theoretical validity. With this in mind, one can begin to envision that the answer to both diagnosis and prognosis for HIV falls outside of a solely individualistic behavioral paradigm. Instead of proposing individual-level solutions, Stillwagon and Sawyers argue that environmental contributions are much more important for both diagnosis and prognosis when fighting the prevalence of the HIV infection in sub-Saharan Africa. For example, people with nutritional deficiencies, with parasitic diseases, and general poor health, factored in with economic disadvantage, have a greater susceptibility to infectious diseases, whether they are transmitted sexually or by food, water, air, or by other means. Instead, there is a variety of treatments and approaches that should be taken into consideration to lessen the spread of HIV, as it is without question that HIV is empowered in places where death by a variety of diseases is commonplace. Malaria, for instance, increases HIV viral load up to 10 times as much 7 weeks after an episode of fever, and that can more than double heterosexual transmission. Policy in sub-Saharan Africa should shift attention to easily treatable diseases, as Stillwagon and Sayers highlight. The medications that can be used to treat both Helminths and schistosomiosis, both infections that are prevalent in the region, are relatively inexpensive and show a statistically identifiable negative correlation between the treatment of both parasites, genital ulcers, and the reduction of the rate of HIV infection. This means that AIDS and HIV policy needs to reflect a more macro understanding to the cause of HIV infections, and that the case study of sub-Saharan Africa is particularly important to reimagining healthcare from a biosocial approach. In conclusion, as students of sociology, we need to ask if social structures constrain or limit individuals' agency. Is HIV and AIDS truly answered by individual agency and explained solely through individual behavior? We need to both be critical of the ethnocentric knowledge production of the globalized university and the tendency for individuals and researchers to give into confirmation bias. Solutions to global health problems can be achieved only with recognition of the interaction among pathogens, hosts, and the environment. Confirmation bias is the tendency to search for, interpret, favor, and recall information in a way that supports one's prior beliefs or values. In Why Circumcision, an Iranian anthropologist named Homa Hudfar decided in the discipline of global health that she would look at health issues in societies and around the world. She embarked on a trip where she worked in Cairo in the 1980s and studied their cultural practice of female circumcision in hopes of differentiating between cultural differences and structural violence. Female genital cutting has been named as female circumcision, female genital mutilation, and female genital modification. Hudfar emphasized that these different names reflect the different attitudes of the people using the term. Female circumcision has been prohibited by the Egyptian government when they launched a campaign against it in the 60s. However, the vast majority of women that Hudfar knew, regardless of social factors, were circumcised. She explains that there are several reasons given for the opposition of this practice. It is a surgery on girls too young to consent, it results in a lack of sexual enjoyment, it is oppressive to women, and it is medically dangerous. However, the fact of the matter is that there is not enough evidence that proves it is medically dangerous itself. The issue is the surgery itself lacks anesthetics and a sterile context. Most individuals believe it is a violation of human rights. Some cultures claim that it is Islamic religion practice. However, the practice is not required by Islam, and many Muslim countries around the world do not engage in this practice. Meanwhile, some Christian cultures do. It is required for male circumcision in Islam, but not females. It is said that this Egyptian cultural practice is motivated by Egyptian beauty standards, marriageability, and social norms. However, even in societies with high rates of this practice, there are indications that this practice is changing, not because of activists, but because of modernization in general. In the 1980s, Huma Hudfar made friendships with lower to middle class women in Cairo, Egypt, to learn about the dynamics of their marriages. These women helped Hudfar by revealing perspectives that were different from Americans. They explained that there was an important responsibility of parents to ensure that their children are socialized into proper gender roles and have appropriate sexual desires. With this in mind, circumcision is viewed as a crucial time through which the sexuality of boys and girls is enhanced. This in turn is a step forward that ensures a successful marriage and family life for them. This is regarded as the most important event in the lives of boys and girls between birth and marriage. For boys, circumcision is regarded as a sanitary requirement that improves their personal hygiene. These circumcisions took place when boys were about 8 or 9. Typically, there would be a little celebration or ceremony where the boy is kept indoors for a few days and would be given sweets and sometimes a new toy. Neighbors would visit and congratulate the family, but parents made sure to refrain from mentioning the boy's pain and discomfort. Fathers were actively involved in decisions regarding their son's circumcision. For girls, circumcision is regarded as a way to ensure femininity and fertility, as it is part of their preparation for marriage and motherhood. This practice typically took place between the ages of 8 and 12. Although circumcisions were celebrated in the past by women, neighbors, and relatives, it is no longer like that. These celebrations are now much more modest and now generally consist of visits from female close friends and female relatives. It's important to note that fathers' husbands had no opinion on the subject, and then it was ultimately up to the mother. Fathers who are reluctant towards this practice would have to accept the responsibilities that their daughters could potentially not find good suitors because everyone would know if their daughter was not circumcised. It was socially sanctioned that uncircumcised women would be subjected to unhappy marriages, and fathers would not take the chance of endangering their daughter's marriageability and chances of motherhood. Ultimately, Hoodfar's findings found that female circumcision was a common experience of girls and as rites of passages to the feminine world. This is a decision decided amongst women, therefore the widely held belief that circumcision is meant to control women's sexuality has been debunked. Intimate partner violence is defined as the physical, sexual, or emotional abuse in a relationship. The United Nations has estimated 600 million women live where IPV is not considered a crime. And additionally, research has found that 30% of women will experience IPV in their lifetime. Variables that have been researched that correlate to IPV include alcohol use, childhood exposure to violence, education levels for women, and poverty. The short-term and long-term consequences of IPV is that it is the leading cause of homicide, as well as increased levels of depression and suicide due to domestic violence. A review of all available data on IPV at national and subnational levels studied 26 medical and social sciences databases, as well as using the WHO's multi-country study on women's health and domestic violence. This study presented data from 141 studies in 81 countries. Here it was discovered that in 2010, 30% of women 15 or older will experience IPV at some point in their life. At a national standpoint, it is important to see how the economic rights and discrimination in family law may affect the rate of IPV. At a community level, male control in the private home and life must be changed in order to properly do something. In order to make a difference internationally, continued research, understanding, and interventions must be made available. As the coronavirus continues to spread across the world, it brings with it multiple new stresses, including physical and psychological health risks, isolation and loneliness, to the closure of many schools and businesses, economic vulnerability, and job losses. Violence against women is highly prevalent, and intimate partner violence is the most common form of violence. During health emergencies such as the COVID-19 pandemic, violence against women tends to increase. This puts women in abusive relationships more at risk. The disruption of social and productive networks, loss of income, and decreased access to services all can exacerbate the risk of violence for women. Home is not always a safe place to live. In fact, for adults and children living in situations of domestic and familiar violence, home is often the space where physical, psychological, and sexual abuse occurs. While this data are scarce, reports from across the world, including China, the United Kingdom, the United States of America, and other countries suggest a significant increase in domestic violence cases related to the COVID-19 pandemic. Reports from other countries suggest a reduction in survivors seeking services due to a combination of lockdown measures and not wanting to attend health services for fear of infection. These services are more crucial than ever. They provide support and care to victims, survivors experiencing immediate danger and distress. In the UK, Refuge, one of the leading domestic abuse organizations, reported that calls to the UK Domestic Violence Helpline increased by 25% in the 7 days following the announcement of tighter social distancing and lockdown measures. In conclusion, institutions that are supposed to protect women from domestic violence, many weak and underfunded to begin with, are now straining to respond to the increased demand. The voices and needs of victims and survivors are often overlooked and underrepresented in some parts of the media and within policy and political spheres. This pandemic has reinforced important truths. Inequalities related to social detriments of health are magnified during crisis. Thank you for watching.